Professor Sapo is a very famous speaker. In previous 2006, he's a professor and head of neurology University Hospital of Limoges, France. And after from the 2007, he's a head of department and center of neurology and intracranial endovascular therapy in Krupp Hospital Essen in Germany. Now he talked to us about the topic of update on AVM treatment. So please.
Hello, it's a real pleasure for me to be part of the meeting and to have the opportunity to give you some insights in the treatment of brain AVMs. And brain AVMs is changing a lot, even if apparently indications are progressively shrinking, because cure after endovascular treatment of AVMs is rare, because small AVMs embolization is not required. Radiosurgery does a good job, and surgery too, because large AVMs are usually not treated, because treatment is not so easy, and the chances to obtain a cure are not so high. Unless some complications occur, AVMs, even the large ones, at some point they decompensate, they bleed, and then something is to be done. So that today, embolization is often only an adjunct before surgery or radiosurgery is being done. And those rather not good results have been confirmed and increased by Aruba. Aruba shows that unruptured AVM should not be treated because partial treatment, because not good treatment, is not acceptable. And indeed, endovascular treatment is challenging, because we need to use very small microcatheters in very small vessels, so we can harm those vessels, because the understanding of the AVM is the key issue today. And the so-called nidus is a word that just hides our ignorance, because it's a rare disease. How often do you have the opportunity to treat an AVM? It's difficult to feel comfortable in AVM treatment if this is not done on a very, very regular basis, meaning several times per week. And major issue is when we're facing complications. These are not minor complications. Complications related to embolization are dramatic bleeding. So what does transvenous embolization change? It changes a lot. It's a whole change in the concept of embolization, because a partial embolization where further injection of one is stopped because of missing of understanding is not acceptable. It's a change in treatment because we need to understand differently the angular architecture of an AVM, and that's why I don't want to talk about nidus. Nidus is a word showing that you don't know whether it's an artery or a vein, you just call it nidus. In fact, most of the AVM are veins, so that we should focus on the venous segmentation, because transvenous is a curative treatment, and because transvenous is probably the best options for AVMs that are dislocated, where neither surgery or radiosurgery are good. But it still remains a high-risk procedure, because if the vein is occluded and the AVM is not completely embolized, this induces bleeding. And the fact to start to occlude the vein is something that prevents to see the rest of the AVM, which is then a major issue to be able to recognize if something is there. But transvenous and transarterial are not competing, they are complementary. And transvenous embolization is an adjunct to transarterial after significant reduction has been achieved. But in my way to proceed, because of growing importance of transvenous embolization, it changes my way now to achieve transarterial embolization. So why is it possible? Because we can navigate in the veins, and we can even navigate in most veins, but the rules of navigation are different. we cannot do a roadmap by the microcatheter. So to see the vein, we first need to bring a catheter inside the arteries, a microcatheter selectively inside the arteries in order to see the vein we want to get access to. But then we only see one vein and not all the veins around. It's also different because the veins do expand and displace more than do the arteries, so that we do not get the same quality of support as we get in the arteries, because the vessel wall of veins is much more fragile. So this means that we can only go there with the smallest and softest possible microcatheters. No way to go in with quite large material to force it. Everything which is made in the arteries where you need extra support with intermediate catheter, forget it. This is not to be achieved in veins. So why is transvenous embolization possible? Because if you diffuse with a liquid embolic agent from the arteries to the veins, then you can also diffuse from the veins to the arteries. But one of the major points is that you very often have a better access to the shunts, which means if you occlude the shunts, you will occlude the shunt without occluding a lot of normal arteries, as very often in transarterial embolization, and even more in transarterial, where some pressure cooker is achieved. You may change the name of the technique and call it plug technique. It doesn't change the fact that injection is made under high pressure, where you're more likely to occlude normal arteries. So, which patients to treat? And there is a progressive learning curve for those patients to be treated. Probably this kind of AVM where you expect by arterial embolization to cure, and here it's almost a cure, is a good candidate, because at this point the artery is very poorly accessible. You cannot navigate in that, so that any injection is very likely to occlude the pericallosal artery, and is very poorly likely to cure the AVM. So maximum risk, minimal efficient, no transarterial embolization. But if you look at the vein here is easily accessible. Now the catheter has been placed here, and from there you can access to shunts, as was done here. Another situation which is a very good indication for transvenous embolization is those kind of deep located AVMs where arterial navigation is very difficult. You may see here that there are different lenticulous striate arteries. Here is the largest one, but here is one, here is a second one, here is a third one, a fifth one. This is the largest one, and maybe another here. And all this drains within one vein. And the efforts here, sorry, I'm on call, I get back immediately to you. Ja, hallo?
Ja, hallo Chef Krawutschke hier.
Ja.
Ich rufe an wegen einer 79-jährigen Patientin, die über die Notaufnahme gekommen ist.
Okay.
Hat ein Zeitfenster 18:10 Uhr, also
Ja.
knapp 1,5 Stunden, hat 4 Punkte für die linke Hemisphäre und hat da einen proximalen M2-Verschluss, also Truncus inferior.
Dann sofort auf den Tisch. Ich komme. Ja, okay, bis sofort.
Okay,
ja, ja, danke. Tschüss. Okay, so we continue. Here is this deep AVM, which is difficult to access, where from the arteries, where we still manage with many efforts to go here through this artery, requiring a balloon, requiring a magic. This took more than 1 hour. We finally got this point, but even if we reach here, are we sure that from here we're going to occlude all the shunts? Are we sure that we don't block the vein without accessing to the other arteries? And this is why we navigated here a catheter through the veins, which was much more easy and less dangerous than navigation through the artery. And now the venous catheter is in place. And now some coils have been injected, some flow coils in the veins. And now we started to inject through the artery with acrylic glue. and we tried to continue, but we had reflux, we had to stop. And at this point, you still see that some arteries are patent. So what is going to happen now? Either the vein is blocked, and this may induce bleeding, or the artery thrombosis. You don't know. And if it goes into the wrong way, inducing a bleeding, this would be a nightmare in these patients. But if you have the catheter in place, we injected here a couple of drops of onyx, enabling to cure immediately. So nowadays, those kind of patients are only treated by the vein and not by the arteries. So definitely, venous access is here an additional security, and it very often appears to be like this. So which are the best candidates to be treated? Obviously, deep AVMs where there is a difficult arterial navigation, but an easy venous access, where the ischemic risk related to arterial injection is high, where then transvenous embolization carries a much lower ischemic risk, and where the expected cure rate by transarterial embolization is not so high. And in all those patients, a venous access is definitely to be preferred. Now an AVM, which is here located at the medial part of the temporal lobe, in the ambient cistern close to the posterior cerebral artery. And if you look selectively here, you only see en passant feeders alongside here the PCA, so that there is no way to access to the AVM. But look at the vein here. This vein is very well accessible from the lateral sinus, where we put two catheters, achieving a venous pressure cooker, allowing this to be cured, and keeping the artery patent and avoiding any ischemia. By any kind of arterial embolization here, the chances to lose the posterior cerebral artery would have been very high. So the small size of an AVM, it reduces the risk, because if you've got a small size AVM, there are less AV shunts to be treated. And whenever you occlude the vein, you must get sure that all shunts are occluded. And even if the smaller AVMs have quite often a vein which is not so large, so that navigation is not so easy, whenever the vein starts to be very large, you can expect a large amount of shunts and a potentially higher risk. That's why if you begin with transvenous, please keep it to small AVMs. So let's focus on the nidus. Nidus is something which everybody talks about when considering AVMs, which is something here where the level of understanding today is very low, because none of these drawings, this one or this one or this one, explain somehow what's going on. On this one here, we see one red vessel that gets blue, but does it explain here how the vessels come together? The answer is unfortunately no. So nidus is just a word hiding our ignorance. And the fact to do a partial transarterial embolization does not help, because if we reduce partially an AVM, which would be this here, we don't understand more. So by using the arterial pressure cooker, somehow we understand already a little more. Here we've got a small catheter, a very important flow. So when we look at these pictures, we just can say, here is a large vessel, here is a large vein, and there are numerous shunts, or there is a macro shunt. We're afraid, and we will take high concentrated blue. But if we make a plug here with these two acrylic coils, what we call the pressure cooker, which we're using since 10 years, when we do this, and if we reduce the flow, we realize that there are 1, 2, 3 very tortuous arteries arriving in this vein. And suddenly it becomes highly understandable. You can follow each of those arteries within the different loops. You can even draw them. And this is already a way to understand better, but definitely the transvenous injection has been the important way to understand how the venous segmentation is. And this ruptured AVM, the brain stem, is absolutely not understandable. Even if you do here a rotational angiogram, you just see somehow a vein in the middle and you don't see more. But if you navigate with a catheter in the vein that was here, that took a lot of efforts, because always getting through the cavernous sinus is not easy. And now we can see the venous filling of the AVM. And if you follow this venous filling here, you can see the main vein, and the main vein receives some primary veins. And here are the primary vein, here is another one, here is a third one. And the more we proceed, the more we can understand the ways segmentation is being achieved. So that we can draw this, and this is how I would consider AVMs are, with a main vein and primary veins arriving in this venous segmentation with lots of arteries around, which you can draw in another way. So if you compare AVMs to trees, according to the type of venous angioarchitecture, you may look at this vein here. This AVM with the different veins would rather look like this tree, or this kind of AVM here with a single vein and many primary veins all around, which would rather look like a pine tree, or these patients here with both primary veins arriving here, that would rather look like this kind of tree. So this allows us to progressively introduce a stage venous embolization where we just focus on primary veins, isolately occluding the veins, occluding AVM step by step. But this, of course, requires an analysis and understanding of the venous segmentation. And as in this kind of patient here with this extensive AVM taking the whole corpus callosum, you can only understand this when we do what we call the 6D imaging, the fusion of 3D in different colors. And this enables to show how the veins are fragmented, segmented. And here it shows the inferior one to treat the anterior part. And in a second procedure, we did it on a quite similar way, looking again on the venous segmentation, on how here those veins arrive posteriorly, the blue stuff here in these veins. So the little blue vein is the one we're getting now in order to treat the posterior part of the AVM. And as step 3, then we finish the AVM and we could cure this patient. And it's not about doing pictures, but seeing how patients are. And you see here, definitely, this patient now is doing fine. And I can show you many other examples. This is a 20-year-old boy who bled 2 times, 3 transvenous embolization. This is a huge AVM of the corpus callosum with major cognitive impairment. That's why we treated her. Unfortunately, this did not bring her better. But after 6 procedures, we could cure her AVM. Here is a 49-year-old man, he bled twice. You see he's cured. This young boy bled since 15 years, 12 times, until we treated him in 3 steps, transarterial and 2 transvenous, until we could cure him. And this is still work in progress. I treated last week the anterior part. This is still to be done in the next step. And many other equivalents. She was treated here in 4 transvenous steps until we could cure her. Or quite equivalent, insula is a very good territory. This is a growing venous aneurysm. And you see that this is 2020. And after 6 embolization procedures, 3 by the arteries, 3 by the veins, we could cure him. And not only that we cure him, his mother wrote to me if it's okay for him to do skateboard a couple of weeks after the last treatment. So I asked her to send me some pictures to make sure that he was indeed so well. And here's another deep located AVM, 2 steps of transvenous to cure this patient. This kind of insular AVM, again, very good way to treat, but this takes numerous steps. Same thing here. This is a 9-year-old girl 5 procedures, and you see here she is, and she's definitely doing fine. This guy here is a hobby pilot with this large extensive AVM. This is from the posterior circulation. This is from the anterior MCA, where the first step, second step, and third step were transarterial. And then for those remaining parts here, transvenous navigation to finish the AVMs in 2 steps. And he's good. He has no neurologic impairment, no hemianopsy. This is a patient here that after the treatment won again a couple of races. And this is here more challenging. You cannot go through all anastomosis to treat this. This requires transvenous success, partially transvenous and partially transarterial. You see here the guiding the transvenous for the last step, whereas this patient is cured. So I could show many others examples. To conclude, transvenous is a major evolution in the treatment of AVMs. There is less ischemia, there still is a hemorrhagic risk, and after 475 procedures, the risk in our experience is 5.5%. It is not easier than transarterial. It requires a lot of efforts and of understanding. So you must start with deep, small, and ruptured AVMs to go on for transvenous, because whenever you start to occlude the vein, this compartment must be completely occluded and not partially, unless there will be a complication. But we found out that progressively transvenous enables to solve most difficult AVMs that cannot be treated by surgery, while combining transarterials and transvenous by stage embolization. But this treatment requires a high level of dedication, because those treatments are associated with a higher risk. And now I'm done with the lecture. Thank you very much.